Okay, colleagues, thank you very much for joining us again today. It's our Tuesday evenings where we enjoy a number of topics, clinical topics, importantly to build your capacity to keep you updated and eventually improve the overall competency of health workers in our country, our region, so that we are able to provide safe care that is of high quality. Today's clinical care webinar is going to focus on the maternal and perinatal care during COVID-19. We are hoping to finish just around 17 hours, depending on the engagements as we usually have every Tuesday. So you are warmly welcomed to this webinar. Just to say that we do have a mission, which is to improve patient care with educational resources and evidence-based education that enhances clinical practice and your competence. And we hope that through this particular webinars, we are able to drive closer and closer to this mission. Today's webinar is on maternal and perinatal care during COVID-19. The rationale behind this webinar is to explore the latest evidence on the impact of COVID-19 pandemic on the care of pregnant women, perinatal outcomes, and also newborns. Our presenter is Dr. Billy Magagula, which I will introduce in full shortly. But we are honored that in addition to the presenter, we have a panel that would really look at this problem from a different lens. We have Ms. Maria van der Merwe, who's a dietitian. She also has a master's in nutrition and dietetics. We do know that there's going to be discussions around COVID-19, breastfeeding, the risks to the child, what is in the best interest of the child. So we are looking forward to all those discussions. We also have Dr. Amukelani Mtombeni. I think she has joined. I will bring her on board shortly. She's a specialist pediatrician, so that we can also deal with some of the specific issues around how you take care of the child once they are born. And we are very honored to have Prof. Priya Somapillay, who is the head of Department of ONG at the Steve Biko Academic Hospital, and in partnership with the University of Pretoria. She's also a maternal and fetal medicine specialist. I know that her profile goes way beyond these 2 lines, but we have just summarized it for the purpose of this particular webinar. Introducing Dr. Magagula. He is a specialist obstetrician and gynecologist who operates both in the public and private sector, particularly in Mpumalanga. He is responsible for managing women during pregnancy and outside pregnancy, and has a special interest in gynecological oncology. His qualifications include the base qualification in medicine, the diploma in obstetrics, M.Med in obstetrics and gynecology from the University of Pretoria, and is also the fellow of the College of Medicine, where he has also completed further studies in HIV medicine. I am not alone. I am with our regular host, Dr. Joshua Segule, who is an ENT specialist, and I'm going to hand over to him at this point in time to welcome everyone, and to hand over also to Dr. Magagula to start his presentation. Thank you, colleagues.
All right, thank you, Dr. Mawela. Thank you for a warm welcome. Good evening to everyone in attendance, my panelists. Thank you for making time to be with us today. I'll be your moderator between you and attendees, and taking questions, and also leading you into the discussion. From the exciting topic we had in our previous week, discussing the issue of the 4th wave, to another accelerating one, which is COVID and pregnancies. We know generally or globally that there is already challenges in maternal and perinatal care of women, just in general, even with non-COVID. But the COVID has made it even worse, more especially that lack of resources, lack of expertise, and lack of staff in this regard. But we are very excited to have you as panelists to educate us more a bit about these issues that are surrounding us in our hospitals, be it states or private sector. It has always been a challenge. issues around feeding, like Dr. Mawela has said, issues about PURs, a suspected case of COVID, how do we manage them, and issues of just how to manage patients perinatally, so with COVID issues in pregnancy. I welcome you all, and attendees, please feel free to put your comments on the question and Q&A session or chat box or even our WhatsApp line. We're hoping to run this meeting for at least in less than an hour or so, and please fasten your seatbelt and let's enjoy this talk. Dr. Magagula, I hand this meeting over to you. Thank you.
Evening, colleagues. Thank you for the very warm welcome from Dr. Sikole, Dr. Mawela, and I'd like to appreciate the panelists and all the participants that have made time, to join us this evening. I hope my slides have started showing on your side.
Yes, we can see them. You can proceed. Thank you.
Okay, awesome. Okay, I must just put a disclaimer that this presentation will actually not be more on the clinical management of COVID, because there's differing guidelines, from one institution to another. There's really not one guideline that everyone follows or protocol. So I'll actually be presenting in a form of answering questions to probably the most common or frequently asked questions around COVID and pregnancy. And then conclude. So of course, we started with the lockdowns going up to level 5 last year in March. There was a lot of concerns, amongst obstetricians and gynecologists, some of which I just put there on the points. Issues of access to antenatal care. We're all concerned that, we see volumes of patients public as well as in state. How do we now make sure that each woman gets access to antenatal care? And the tricky thing with antenatal care is that telehealth does not really do the job. We have to see and examine our patients. And there was a lot of move, towards telehealth and how perhaps we could get things done. And then there were suggestions as to how we should schedule appointments, how we should, stratify and identify those that are at a high risk that needed to be seen, etc., etc. So there was a lot of concern around that. And of course, issues of delivery, whether we have enough delivering facilities to make sure that those that test COVID positive in pregnancy are actually able to have delivery isolated from everyone else. So issues of facilities was a big issue. And of course, the concern that patients would be worried and scared and skeptical about going to healthcare facilities because of the risk of getting the COVID infection. And another major one was access to contraception and TOP services. We saw a big rise, in the gender-based violence stats, which is already horrific in South Africa, but it got worse, during the lockdown. And this was a big opportunity now for the telehealth for us to continue providing health beyond women, every individual that needed health, to find ways to consult. And probably Dr. Mawela will share at some point, some of the advances that he's also made with regards to telehealth, an app that was developed for us to be able to consult our patients and monitor them remotely. But then there was a publication by Prof. Pattinson. We can see Prof. Somapile was one of the authors in this paper, published in the ONG forum. So this paper basically looked at the effect of the first wave of COVID-19. As you can remember, it ended somewhere in September of last year. And then obviously where they wanted to assess the effect of the wave and the issues of the lockdowns on women accessing maternal as well as reproductive health services. And if these lockdowns or the COVID itself the COVID wave would have an impact in terms of the maternal deaths. We can remember that from the latest Saving Mothers report, our maternal mortality rate was actually on a downward trajectory up until COVID came, and we sort of went up from there. Addressing the issues of the concerns from the previous slide, fortunately, women still went on to have access to antenatal care, which is a good thing. But as we all know that in South Africa, we have a problem of late booking. So late booking being described or defined as a patient that books after 20 weeks of pregnancy. So we had more patients booking late. However, patients were having deliveries in facilities. So there was actually, interestingly enough, a rise in terms of the total number of patients that were delivering in facilities, except for provinces like KZN, where there was a thought to believe that perhaps some of the patients there were actually having home deliveries, which was contrary to the general trend. There was unfortunately a significant drop in terms of access to contraception and TOP services, which, you know, if you read the recent Saving Mothers report, one can already see the effects of early pregnancy complications. I mean, I just dealt with one now. So miscarriages, ectopic pregnancies being actually coming up, you know, rearing their ugly head as one of the causes now of maternal deaths, which we shouldn't have after all the gains we've made all the years. So this is just to show, comparing the first 3 quarters of 2019, looking at the use of contraception, we can already see, if you compare quarter to quarter, the real impact of the wave would actually be from quarter 2, which is also when we had the lockdown, as well as quarter 3 of 2020. And you can clearly see that there was a sharp decline in terms of use or prescription for contraception, which is quite worrying. You know, in all the Saving Mothers reports, it's the first recommendation or the first and most important way to prevent mothers from dying is prevent them from falling pregnant. So this is very, very concerning. Probably many contributing factors as to why women never got their contraceptives, despite the fact that because they had to attend antenatal care, they were coming. But for contraception, the prescriptions and the use was actually very much reduced. Another one, which is very, very sad, in my opinion, we saw a sharp decline in terms of the use of TOP services in quarter 2 compared to that of quarter 2 2019, slightly improving in quarter 3. And I know that in our province, Mpumalanga, where we are, we still have not gotten back, you know, to where we were, even though we're not really where we were in terms of TOP services. I think it's actually a nationwide problem. TOP services, and these have to be available. It's a woman's right. There's so many studies, you know, that have been published to show that once the Choice of Termination of Pregnancy Act was instituted, there was a significant reduction in maternal deaths. There was a significant reduction in sepsis associated with miscarriage. I mean, Prof. Mhlanga and Prof. Sneeman, so many publications around termination of pregnancies. And I think we should really strive to offer women this service as they need, rather than them going for unsafe TOPs, which usually is the only option that they have because there's no other service available for them. Now, as I mentioned when we started, that there was a significant increase in the maternal mortality. If you look at the number of deaths in 2019, 441, and in September 2020, having gone up, you know, by 132, 30% increase in maternal deaths. Very, very much worrying. Multiple contributing factors already. We've mentioned the issue of early pregnancy and problems. So this was very, very much concerning, and I hope it will be a lesson, you know, as we go through these lockdowns, to put systems in place that women are able to access all these services they need, despite us trying to fight off the COVID that we are actually going through as we speak. So this will probably be one of the questions in the poll. Yeah, one of the common questions that get asked to say, is the maternal mortality and morbidity increased when it comes to COVID-19? So we'll see what the participants say. I see it's going up and down, but it looks like many people agree so far that the mortality and morbidity is actually raised with COVID-19. You'll remember from early studies that many of the findings were that the trend or the behavior of COVID-19 in pregnancy is actually quite similar to the general non-pregnant population. But several studies have actually come out. We have one of our own, or I see, the majority says agree. So we're gonna move on to the next slide. We have our own study, which I'll share with the colleagues and the forum, that basically shows that actually the morbidity and mortality is higher, and the outcomes tend to be poorer with in patients that have COVID-19. So I came across this systematic review and meta-analysis. It's a living systematic review, meaning as the data comes in, it gets updated. But this publication was published in February by Atelier et al., where they basically looked at the manifestations, the risk factors, as well as the outcomes, the obstetric outcomes of patients that had COVID-19 in pregnancy. They found 192 studies which were eligible and were included in their search. And the total number of women was about 64,000 that were pregnant, or those that recently were pregnant and had COVID-19 within the 42 days of the puerperium. And 560,000 women that were non-pregnant, but women of reproductive age, sort of as the control group. So just to show their findings, so when they compared pregnant women that had COVID-19 with those that were not pregnant with COVID-19 and those that were pregnant without COVID-19, just to show the impact in terms of the mortality and morbidity. You can already see the odds ratio. It's quite a busy table, so you can just focus your attention to where the rectangle is. And you can see that the odds ratio for ICU admissions, invasive ventilation, hyperbaric oxygenation, as well as use of oxygen and major organ failure was significantly increased when they compared these pregnant women with COVID and those that were non-pregnant with COVID and those that were pregnant without COVID. So this just shows us that clearly there must be something that COVID does that increases the maternal mortality and morbidity. And you can already see from the observational study that was published by Prof. Pattinson and et al. In the ONG forum that there was a 30% increase. And at the time, it was not clear what was the actual cause of this mortality. It was believed that it may be some direct or even possibly indirect effect of COVID-19 that led to all these maternal deaths. But as we can see, the evidence is actually coming up to say there actually is an increase in mortality and morbidity. There's also the inter-COVID study that showed that patients that actually had symptoms for COVID-19 and subsequently admitted had a higher mortality than the other patients that were admitted for other reasons. And in this meta-analysis, they basically looked at all patients that were admitted with COVID, but admitted for any other reason. And it was shown that in fact, in all patients with COVID, whether or not they had symptoms, their outcomes were poorer, both maternal as well as neonatal. As you can see, the stillbirth rates and the neonatal deaths and etc. With higher odds ratios. And the risk factors that were associated with poor outcomes in this systematic review were advanced maternal age, non-Caucasian race, poorer socioeconomics, high BMI, and other comorbid conditions, as we already know that in the general population, having a comorbidity increases the risk that you could have severe disease. So that was also true for pregnant patients in this meta-analysis. And then, I've kept you in suspense. This one excites me because from probably many of the audience, they know many names that are on there. And again, Prof. Somapile's name also comes up, but the lead author being Samantha Budram. So they basically looked at the outcomes of women that were admitted with COVID-19. All women admitted with COVID-19 in South Africa. And this study was in many provinces, about 6 provinces in the country, 36 hospitals. And they had about 600 pregnant women with COVID-19. So whether admitted with COVID-19 because of COVID-19 or any other reason for the admission. It was also a cohort study, observational study. There was no control group though here, but the outcomes were basically on the patients that were admitted with COVID-19. And then the common risk factor that was seen when comparing those that were admitted for other medical conditions and those that were admitted for COVID, it looked like TB was the commonest risk factor. We don't see all the other risk factors as mentioned in the meta-analysis that I just described. And then, of course, when they looked at the outcomes, so comparing the outcomes for patients that were admitted primarily because of COVID disease and those patients that were admitted for other indications, you can see that, the p-values are quite significant for patients that required ventilation because they admitted for COVID, patients that were in distress, patients that had septicemia, renal failure, pulmonary edema. This is almost like a repetition of what the outcomes was in that meta-analysis, showing that being admitted for COVID and being pregnant is actually a risk factor for one becoming severely and severely sick. Otherwise, the other perinatal outcomes, not much to talk about there. The interesting thing is that the protocol of this study is similar to the UKOSS study, where they basically look at, they also looked at similar kind of study design where they looked at the outcomes. And in that study, there was no significant increase in terms of the morbidity and mortality. But in our study, here in South Africa, you could see quite a significant increase, which is in line with the previous meta-analysis already published early on in February. This one was published recently now in September in the International Journal of Obs and Gynae. Okay, the next big question is it possible for the baby to get COVID-19 from the mother? We'll see what the poll says on this one. Very, very interesting. Perhaps, while the poll is running, why does it even matter? You'd remember when we had the Zika outbreak, we're all concerned about what it might do to the baby and congenital issues. It's actually quite similar as well, because we don't know if it has any potential teratogenic effects or whether it can cause growth restrictions, stillbirth, and all that. But data, of course, is coming, on a daily basis and showing what potentially COVID can do to the baby. In the long term, again, it's only been almost just over a year now with COVID, so we don't really know what the long-term outcomes are. So it becomes very important for us to talk about the issues of whether or not it's possible for the baby to get COVID-19 from the mother. I see many people say, yes, it's possible to get COVID-19, for the baby to get COVID-19 from the mother. Well, let's see what the data says. Thank you for that, Dr. Ellis. Well, I came across this one systematic review and meta-analysis. This one was published in July in the AJOC. It basically looked at vertical transmission of COVID, as we've just described. And this was a systematic review. It's actually better to look at systematic reviews and meta-analysis because many of the data comes from, observational studies and case reports, and so very difficult to interpret. So putting all of them in one and trying to interpret is actually a better way to look at COVID data generally. So in this study, they identified 936 neonates that were born to moms that were infected with COVID. And then these are the sites where they actually sampled and sent for the COVID PCR. So the nasopharyngeal one seems to be the one that had the highest yield of positive results. The placenta as well. We know that the placenta has got the ACE2 receptors, which the spike proteins actually go for. Cord blood, amniotic fluid, and you can see neonatal urine as well, feces as well as serology. So I think the important thing with serology is that if a baby has got IgMs immediately at birth for whatever possible infection they may have been exposed to, the primary assumption is that they actually develop those IgMs from being exposed or being infected with whatever pathogen. So a positive IgM is highly suspicious of vertical transmission or in utero transmission. Of course, it depends when in the neonatal period the IgMs are done, because we do know that they don't cross the placenta, so they cannot be maternal. But if it's IgGs, it's a different story. Those can actually cross the placenta and can be detected in the baby's serum. So the biggest yield of positive results in this review, it was more on the nasopharyngeal swabs. Unfortunately, I couldn't get my cursor going, but this is a forest plot that included all the studies that they could find. And you can see the biggest study here was the study by night. That's the one that had about 244 swabs done, and of those swabs there's about 4.9% of them that came back positive. You can see the confidence intervals are not that wide actually of most of the studies. Quite many of them, of course, yes, they did not find positive PCRs on the nasopharyngeal swabs, but there were quite a few where the nasopharyngeal swabs came in about 3.2% of all these swabs that were done. And you can see the heterogeneity between all these studies is 0.00, and the confidence intervals are actually not that wide. So probably reliable data, but yeah, it's still a very, very controversial issue. So in summary, in this study, they found about 27 of 936 neonates that tested PCR positive on the nasopharyngeal swabs. And that made about 3.2% positivity rate. Now, to just mention that they actually did the swabs at birth up until 48 hours. And then one obviously would have to define what vertical transmission is. Because how do we then differentiate between a baby that got COVID-19 in utero versus the one that got contaminated at the time of delivery? Because we do know that the genital tract, the uterus, the ovaries, the fallopian tubes, they all express the ACE2 receptors. And possibly there might be even COVID there that can contaminate the baby, be it born NVD or born by cesarean section. So this paper sort of tried to clear that ground for us to have clear definitions, which unfortunately we don't have yet. And by definition, according to the authors of this paper, published as well late last year in the American Journal of Perinatology, was that for us to say it's actually intrauterine infection, the baby must have a positive PCR within 24 hours, regardless of the source or the site of the sampling. And as well as positive IgMs, you'll remember that we said IgMs, obviously when the baby is infected, they'll produce their own. There must be evidence that within the first week, they are developing their own IgMs. That will actually be evidence that this baby got COVID-19 intrauterine. Now, what about being infected at the time of delivery, as well as immediately postpartum, either from the healthcare worker that helped with the delivery, or from the suction tubes, or that oxygen neopuff, or even from the mother during breastfeeding? Then those ones would actually be defined as a negative PCR done within 24 hours, and then a rise in IgMs 2 to 3 weeks after, giving enough time for the baby to be infected, be in the incubation period, and then start mounting an immune response. And for those babies that were contaminated by COVID from the process of delivery, you would actually find that the PCR is positive within 24 to 48 hours, but with no immune response at all. Then we'll assume that this baby was actually contaminated, because they don't show the evidence of infection. Perhaps this might help to standardize the definition, and then we'll have clearer answers as to whether they really vertically transmitted this 3.2% of babies in the previous review that I mentioned. The initial data, to just mention, that suggested possible transmission, because all along, it was believed that it is not possible to transmit COVID-19 to the baby in utero. They started off in China, and their rates were around 2%. And these rates are sort of similar to many possible congenital infections that may occur, particularly in the third trimester. So yeah, we still don't have the answer, but the data suggests possibility of vertical transmission. As to how we actually define that, it's a story for another day. As you can see, that the story really gets very complicated from now on. Okay, an exciting one. Vaccination. This one has divided the country. It's probably, the only thing in our armamentarium against COVID-19. Sadly, there's so many false stories around it. But I think the current position in South Africa and the whole world is summarized by that YouTube video that Prof. SP had, an interview with the ENCA news guys, actually the Newsroom Africa guys, where they basically described what it is that is recommended with regards to COVID-19 and vaccination of women in general. And the bottom line is, when I consult with my patients, I always say to them, when it comes to the COVID vaccine, summary, it's recommended. Obviously, people have got beliefs and thoughts, and if she's interested, then you provide all the information which we'll talk about just now. But yeah, it's recommended by WHO from a while back already, by the Department of Health as early as July. SASOC has also done the same, and the colleges of obstetricians and gynecologists in the CMSA have also recommended that we offer COVID-19 vaccines to women that are pregnant, as well as women of reproductive age that are not pregnant. Just to also mention that previously it was said that we should not offer the vaccine up until the woman is beyond 14 weeks. There is an update to that, and it can actually be offered at any point in the pregnancy. Even in the first trimester, it can be offered. And obviously, women will always ask, is it safe? And what can this vaccine potentially do to my baby? The simple answer to that is that, with COVID-19, we learn as we go. There's no randomized control trials. There's no big trials with control groups of those that take and those that don't. And then we see and track what happens to the others. But we do know that worldwide, women have been vaccinating during pregnancy, during lactation, when they were planning a pregnancy, and none of the observational trials have actually shown that there is potential harm. But it's always good to mention to the patient that, of course, when they were testing all these vaccines, all these types of vaccines, pregnant women were not part of the testing. But I always make the example of Panado as well, that when they tested Panado, they never included pregnant women, but we know that paracetamol can potentially be safe, or is actually safe in pregnancy, by using it and no one reporting an adverse effect on the baby or themselves. So same applies to the COVID-19. We learn as we go. And so far, there's no evidence of harm, be it the Pfizer vaccine, which is the one we have, the mRNA, or the vector-based vaccine, the AstraZeneca, as well as the Johnson & Johnson vaccine. There's not been any reports of harm. Of course, there are several reports that mention localized injection site reactions, headaches that usually disappear within 48 hours, fever here and there. And yes, the thrombotic events that were associated with the vector-based vaccines, another one that actually talked about quite a lot. But then remember, I mean, the risk of a patient developing that is less than 0.0. I can't even remember the percentage, but it's very, very low. And we always say that COCs, or combined hormonal contraceptives, actually cause thrombotic events more frequently than these vaccines do. Yeah, so they are relatively safe, and of course we learn as we go. As one can imagine, probably not much systematic reviews at this point, because we just started vaccinating pregnant women as well as lactating women recently. So hopefully soon we'll see some more. But I just came across this cohort study, another study that was done in the US, recently published as well on the 1st of September. It's a cohort study where they basically looked at the immune or the vaccine response in patients that were vaccinated with the Pfizer vaccine and the Moderna, which is what they use on the other side. So these are the mRNA platform vaccines. We don't have much data on the J&J or the Johnson & Johnson vaccine, which is a vector-based vaccine. So yeah, we do have data, but probably there shouldn't be much difference between the two. Now, in this cohort study, they had about 131 participants. So this was a prospective cohort. And these are people that were not necessarily recruited to become part of the study, but it's people that volunteered and wanted to get the vaccine, regardless of the fact that they were pregnant or lactating. So in total, there was 131 participants, 84 of which were pregnant women, 31 lactating, and 16 that were non-pregnant. The next few slides, unfortunately, they also need me to have a cursor, but I'll just describe, and I'm sure the participants can follow. So these are violin plots. They basically indicate the response, the immune response of the recipient of the vaccine. On the y-axis of each, it's the immunoglobulins and the degree of response. And on the x-axis, V0 is when the participant is at baseline or when they receive the first shot, because these are the ones where actually we give two doses. So there's the first dose and then there's the booster dose. So V1 would be after the second dose, and V2 would be 2 to 6 weeks after the second dose to evaluate the immune response. And then looking at the color codes of those violin-shaped bars there, on the far right, so that would be the immune response. If you look at A, on the far right, that would be the immune response of a lactating woman. And the second one to that, going towards the left, would be a patient that's pregnant. And then the one next to that would be the non-pregnant patient. And V0, obviously, there's no immune response at the time. And immediately when you get the first shot, then you can see a rapid increase in terms of the immunoglobulins by the time the patient gets the second jab, which is at V1, and then which is slightly increased as the patient gets the second jab, quite significantly. I'll just draw everyone's attention to F. Now, F, it's one that perhaps we should use, to counsel our patient who are very skeptical about getting the vaccination. So yellow, it's patients that get infected naturally and they don't get the vaccine. You can already see the height, of those bars are actually quite short compared to patients that are vaccinated, where the height of those bars, whether they are pregnant, non-pregnant, lactating, are actually very, very high. About IgGs that they cross the placenta and protect the baby. So it basically means that at birth, this baby potentially has got some degree of protection from the virus. And we know that vaccinated people actually transmit the virus less because it doesn't replicate as much as a non-vaccinated person, which are all the more reasons for us to advocate for COVID-19 vaccination. I just avoided taking some screenshots of some of the debates, in the online media and the print media. One I saw was when the deans were also suggesting that all medical students must get vaccinations, and a lot of employers saying their employees must actually get the vaccine or they face, being jobless. I actually saw a client 2 days ago who works for one of the non-governmental organizations in the health sector, and she's been given a deadline to vaccinate or face losing her job. I don't think it should get to that point, and I hope many of us as healthcare workers will really consider our position when it comes to vaccination and be more logical about things. So this slide basically shows the benefit which we just spoke about, the transfer of IgGs or immunoglobulins to the baby. Same study. You can just see the immunoglobulins, after the first jab, there's not much being expressed into the breast milk, but after the first and after the second jab, then there's a significant increase in terms of immunoglobulins that potentially can protect the baby from COVID-19. So yeah, it's very, very important for us to have this discussion continuously. And then this is my last slide. In summary, the impact of COVID-19 on maternal health services has been not so great. We've seen a rapid increase in maternal deaths, something that shouldn't happen. We still have to offer women choice of termination of pregnancy services, contraception. We should always be open, and we should have means of transport for women that need care, so they shouldn't feel stuck to their homes because, we're in lockdown 5 and no one should move, and hence they have home deliveries and they die from complications of early pregnancy. And I think we've clearly answered this one to say the morbidity and mortality risk is actually very high when a woman has got COVID-19 and she's pregnant. When it comes to the issue of vertical transmission, we have to clear our definitions of what we mean by vertical transmission. But so far, it looks like it actually is a possibility. And yes, we have to advocate for vaccination of women of reproductive age. We should, in my opinion, all of us never be coerced to vaccinate, as we're never coerced when our parents took us for the BCG, for the DPT, for the rubella vaccine that we got when we were kids and we were not even aware. And fortunately, none of us have rubella today, none of us have polio today, because our parents made reasonable choices which were good for us. And that, I thank you. The references would be available to anyone who is interested. Thank you.
Wow. Thank you. Thank you so much, Dr. Magabula. Quite interesting, informative, and brief discussion. Before we go into it, I just want to take this moment and applaud you. Appreciate your time. For those who know me, they know I'm a man of citation and quotations. Research comes very close to my heart. I always say it in this clinical care platform that nothing can beat research, nothing can beat evidence-based medicine. And what we have shown us is true leadership and evidence, and congratulations to your study there. And with Prof. Soma as well, keep up the good job that you guys are doing. But as I always challenge my panelists, I urge you to do more. We need our own, a lot of our own, especially relating to vaccination in pregnancy and early childhood. I'll urge you to do more studies in that regard, Without any further ado, I'm going to take my panelists. Please, if you can just keep it brief, if possible, under 5 minutes. Just your comments towards this presentation, your additions, and then I've got quite a lot of questions for you, hence I'm asking for brief comments. I'll start with Prof. Soma, please. Your comments, Prof.
Thank you very much, Billy. That was an excellent presentation. Thank you. I think you covered the topic quite widely. I don't have much to add, but just to say that from data, both in South Africa and mainly from the UK and US, pregnant women in the 3rd trimester are actually most vulnerable for morbidity and mortality from COVID disease. The physiological changes in pregnancy are more exaggerated. One's lung capacity is decreased, and we've seen that women after 26, 28 weeks gestation are more likely to be admitted. So that is the vulnerable period, and we need to encourage our women to be vaccinated before they enter the 3rd trimester, and preferably have both doses of the vaccine if they're going to take the Pfizer vaccine. Thanks.
All right, thank you, Prof. You leave me no choice but just to respond to you and go back to you before I go to Maria, because there was one of the questions in the plot or in the chat, and you touched a bit on it. Maybe you can just further evaluate just briefly. Is pregnancy regarded as a risk factor for severe COVID? And if that's the case, how so? I just heard you briefly talking about lung capacity and all that. There were questions around, is it because there's an increased physiological state or increased oxygen demand? While we're still on it, can you just please enlighten us? How does pregnancy become a risk factor for severe COVID?
So from our data that we've seen and from the mortality rates that Dr. Magagula has described, in South Africa, we've looked at our data in the 2nd wave as well, and we've had a 40% increase in maternal mortality since the start of the COVID pandemic. This has been both due to direct and indirect effects, as Dr. Magagula has said. We've seen that young women, and particularly in the 1st and 2nd trimester, tend to do reasonably well. But there are women with comorbidities, particularly those advanced maternal age with comorbidities like hypertension, diabetes, and if they contract COVID in the 3rd trimester, are susceptible to morbidity and mortality. And from our South African obstetric surveillance data, women who are admitted for COVID in our hospitals, not women who were admitted and tested positive, were going for elective Caesar and tested positive. Those who were sick and were admitted for COVID, 1 in 8 were admitted to or needed tertiary ICU admission, and 1 in 16 died. So pregnancy does pose a risk, but there's certain risk categories, and that's your obese patients, advanced maternal age, particularly women above the age of 40, those with diabetes and with hypertension. And like I said, the physiological changes become exaggerated in the 3rd trimester. Your estrogen and progesterone level increases. That produces more mucus in the respiratory tract. Your functional lung capacity decreases. As the uterus expands, it exerts an upward pressure on the lungs. Your residual volume is decreased. And with COVID, which is mainly a virus affecting your respiratory tract, your lung capacity is affected and your lung function is affected. So we've also seen an increase in cesarean section rates, particularly in the 3rd trimester. And this is not for fetal reasons, but mainly to improve maternal function and to assist with maternal ventilation. And this was the reason for the increase in cesarean section rates.
Thank you. Thank you so much. Thank you, Prof. Loud and clear. Maria van der Merwe, please, your comments. Thank you.
Thank you very much, Dr. Sekoli, and thank you to Dr. Magagula for the presentation. I think to be honest, Dr. Magagula, preparing for today, I thought I had the latest data, but you bowled me on one or two, but even more up to date. So I think with that, what I'm saying is the importance of staying up to date, whether that would be global recommendations or national recommendations from our health authorities. And we know obviously with COVID, there's a lot of research ongoing and recommendations are very lively and they change. That may also be why we have such skepticism about recommendations and about what we see daily in social media and other platforms in terms of the confusion. So maybe just to confirm the importance of us as health workers to be up to date and to know what the latest recommendations are and have a full understanding of what that implies when we have a patient in front of us. And then I also always remind myself and my colleagues that when we talk public health, which is the purpose of an event like this today, it's general public health guidelines, recommendations. But when we have one person in front of us, to always then consider individual circumstances when we have that discussion, whether that is about vaccination, etc. We know what the guidelines are, but don't forget the individual in front of you with a personal context, comorbidities, etc. That may be different. And for that, we need to be up to date with the latest. So thank you very much for the update, Dr. Magagula. I think it was very clearly presented, current, and yeah, I'm looking forward to further discussions. Thank you.
Thank you. Thank you so much for your valuable comments. Dr. Mawela, did you manage to upgrade Dr. Amukelane to the panelist, our pediatrician?
Yes, I think before she comes on board, there were quite a number of questions around breastfeeding and the baby.
Yes, I'm still going to go into those questions.
All right, thanks.
I just want to give I'm coming back to you, don't worry. I just want Amu to say a word or two before we go into those questions and discussions. Amukelane?
She may unmute, thanks.
Hello, everyone. Can you hear me?
Yes, we can hear you, but you're a bit faint. You can come closer to your mic.
Okay, am I a bit audible now?
Yes.
Yes, that's better. Thank you.
Thank you. I've been struggling with the app for quite a bit. Sorry. Thank you for the invite, Dr. Magagula. That was quite informative. Actually, I don't think anyone can do a better job than this. This was concise and you've covered basically everything, even the pediatric part, I think. But for me, what has stand out in terms of managing the neonatal, in terms of handling neonatal care during the pandemic, it's actually the isolation part. So SOPs have been set out. Everything has been working well. Some institutions have got disposable resuscitation boxes, some don't. That's all resource related. However, I feel that in terms of COVID, we have been so focused on the clinical aspect of diagnosing the COVID, making sure those PCRs are done, making sure that these mothers are isolated. And I think mental health care has been a bit compromised for most of the mummies that we see. I'm not sure if this is in the whole of South Africa, because I haven't come across any studies in terms of prioritizing mental health care for mummies, but definitely in the West Rand, I don't remember seeing a mom being screened properly if they already have underlying anxiety, if they've got underlying depressive disorders, so things like that. And isolating these babies from mummies I've seen that it creates a lot of anxiety. There isn't pretty much anything that we can do about it. But then as a clinician, it is something that I'd like to put out there to say when we pick up that a mommy is positive rather, or they are symptomatic, when we isolate this baby, how much care are we giving in terms of the mental health of this mommy? What is the later repercussions of these actions? Like I said, there isn't much that anybody can do about isolating baby from mom when there is a need, especially the preemies that will come and need ventilation. We don't have specialized units for COVID patients. No one was ever prepared for this. But for me, the mental well-being of mothers, I feel that has been compromised a lot. And maybe, just maybe, after looking at all of this, we could do a study on that, unless somebody knows of one. So that has been the one challenge that I've felt that we're not addressing enough. And breastfeeding on its own is quite beneficial. There's been studies, CDC have released all of that. We need to continue breastfeeding for the rest of the other benefits, rather, of breastfeeding. So I think that in all of this, where is mental health care of mothers? I know, I'm speaking as a pediatrician, I know, but for me, mommy and baby are actually a single entity. But then let me not hold the conversation. Back to you.
Thank you so much. Quite important. Yes, very true. Just like we have discussed last week in this platform, the education to the community is one of the key areas, regardless or whether it's pregnant or not pregnant. So that's another aspect that we discuss. We need to educate more and mind more. We have discussed previously in this platform about mental health issues in relation to COVID, including the pregnant ladies. In 2 weeks' time, we can guarantee you we'll be having one of the great speakers who'll be giving us that kind of a talk. Should you have time to attend, it's very important. Thank you, Amgela, and I think this is one thing that is being neglected, especially to the communities. To us as healthcare workers, it might be easy because we've got access to these things, but to the communities, how do we deal with it? Our psychiatric colleague will give us more information about that next week. Yes, maybe you can collaborate to make a study in that. We appreciate and we love studies, okay? Thank you so much. Prof, I'm going to start with you. I've got 2 questions that are non-clinicals. Are you ready? Prof.
Yes.
Are you still with us?
Yes, I am. Can you hear me?
Yeah. Yes, in his presentation, he said, and you also added, that it's actually not 30%, but 40% increase in the death rate, which we said is very worrying, especially among the pregnant women since the pandemic. And you have alluded that it could be factors that are direct or indirect. My question is not clinical, but rather non-clinical. From the Obstetrics and Gynecological Society, what are the measures that you have put in place so that we can reduce this mortality rate?
So from our ONG society, it's difficult to put in, majority of our patients use the public sector, and only about less than 20% actually use private sector. But from our side, we've come up with vaccine or patient information leaflets. We've had several webinars educating our doctors, because we found that there's also been vaccine hesitancy amongst doctors, and doctors are not encouraging their patients to get vaccinated. So one of the ways in which we can, or I think vaccine is the only armor that we have to fight this pandemic, is to get as many people vaccinated as possible, both pregnant women and non-pregnant individuals. And women contemplating pregnancy should get vaccinated prior to their pregnancy. So we've done quite a lot of work in trying to advocate for vaccines. We've put out patient information leaflets, we've put out our statement, and we've created quite a lot of awareness. So we've done a lot with that. In terms of access to care, it's been difficult, and I think the state sector has been affected more in terms of TOP clinics and contraception clinics. So that is a difficult path for us to thread into and to do something. But we have tried in terms of advocacy and education.
All right, thank you. Sometimes we have discussed in the platform before, we tend to focus more in our big hospitals, and we forget the primary healthcare. During the antenatal visit, especially primary healthcare, that's one key area that we must also revisit in terms of teaching our staff so that they can educate or transfer this information to our mothers before they become high risk. Thank you so much, Prof. A follow-up question to that, Prof, rather a comment, is that we have seen in the media or in the news that we had teen pregnancy in South Africa jumping up to 60%, especially in Gauteng. there have been reports that at least over 23,000 young girls under the age of 18 have fallen pregnant during the lockdown. What is your take on that?
So we've actually predicted that from our data and the paper that we published in the ONG forum that Dr. Magagula presented. And if you look at the graphs that we've seen, and the visits to antenatal clinic went down sharply when it and coincided with the level of the lockdown. So when we were at level 5, our antenatal visits, our contraceptive clinic visits, our TOP visits went down sharply. And these are the indirect effects of COVID. Transport was restricted for our young girls. They weren't at school, they were at home. They were distracted by other things. And so these are the indirect effects which we have predicted. So I think we need to prepare for future pandemics. With things like climate change, we are going to see future pandemics, and we need to prepare for this. And we need to strategize and look at ways in which we can maintain our services even though we have a pandemic. So I think this is something that we must learn from, and we need to look at how we can maintain our services, particularly antenatal care, TOP services, contraceptive services, and then education plays an important role as well.
Thank you. Thank you so much, Prof. Yes, like I've said in our previous meeting, last week, Tuesday, we were discussing the issues on fourth wave, whether it's coming or not. For most of us, we feel that it will hit us somewhere in November, December. We're looking into another discussion on how to prevent further mortality and increase transmissibility or positivity rate in the fourth wave. Probably we'll invite you in that platform so that you can give your inputs in respect to maternity. Thank you so much. Maria.
Thank you.
Are you ready? Sorry, simple questions, don't worry. There was a question on the plot which says, is it mandatory for COVID mothers to breastfeed?
I think it's all about wording in that question. So mandatory is a loaded word, because I think it's never mandatory for any mother to breastfeed or not breastfeed. So it will all be about what's the recommendation. And along with the recommendation, I would add in the context of what we discussed earlier about Dr. Mtombeni is also the support we give the mother when she makes a decision about infant feeding. So the recommendation, irrespective of COVID status, remains exactly the same, that infant should be exclusively breastfed for the first 6 months of life. After that, continue breastfeeding with the addition of complementary foods that are appropriate, safe, and adequate, and continue breastfeeding 2 years and beyond. So that would then be the general recommendation. So if we look at COVID and we look at breastfeeding, the important question, and I think it is the second question that I might just jump into, Dr. Sipole, is if there is an indication that COVID-19 is transmitted through breast milk. So there we can refer back to May 20, let me get the right year, 2020, last year. So that was fairly new in the whole pandemic. The WHO brought out its first statement about breastfeeding and COVID-19. And at that time, a systematic review consisted of 46 mother and infant dyads. And very interesting, out of the 46 samples of breast milk, only 3 tested positive, not for the live virus, but for mRNA, apologies, not mRNA, for RNA particles of the virus. And of the 3 breast milk samples that tested positive for viral particles, 1 infant tested positive, one of those 3 pairs, mother-baby pairs, but there was no information on what mode of feeding that baby received. The other 2 out of the 3 breast babies were fed breast milk. The one was fed on the breast and the other one expressed breast milk, but they were both tested negative. So based on this very early review and indication, it was the recommendation that mothers should be encouraged within the clinical context and obviously within the context of disease severity. So if a mother is ventilated, that's a different situation. If the baby requires neonatal ICU care, it's different. But the general recommendation is that mothers should be encouraged to initiate or continue breastfeeding irrespective of COVID status. So the next important consideration is that while there is no evidence that breast milk can transfer or transmit COVID-19 to the baby, there's clear evidence that the antibody from the mother, either through having COVID and the antibodies that she produces from infection, or IgA antibodies from vaccination, that can cross both the placenta and it is also present in breast milk. And the very positive evidence that we have there is that antibodies can actually neutralize COVID or the SARS-CoV virus in vitro. So it actually shows us very strong evidence that while we don't have an indication that COVID-19 is transmitted through breast milk, we have a very strong indication that the immunity from the mother, either through infection or through vaccination, is transmitted to the baby through breast milk and therefore gives the baby immune protection. So the conclusion then is where the mother's clinical condition and the baby clinical condition allows for that, and it's possible to breastfeed. For that should be hygiene conditions. Mommy should wash her hands with soap and water before breastfeeding, before touching her breast, and wear a mask when feeding the baby. So we still recommend skin to skin and all the other factors, but we recommend the protection because the highest risk is through droplet and in airborne particles. So that comes down to either breastfeeding on the breast or feeding expressed breast milk to the baby if that is required due to circumstances. And again, hygiene practices being the most important consideration when we handle the expressed breast milk and when we feed our baby.
All right, good. Thank you. Thank you so much. You've heard it, colleagues. We must encourage breastfeeding as long as we protect the baby through the mask, hand washing, and following IPC protocols. Dr. Amukalan, are you still with us?
Yes, I think that was lovely. I think she covered it very, very well. I think the take home
is question for you. Okay. A question for you. She has covered that. Thank you. The question is it standard or should it be standard to swap all babies born to COVID mothers? That's the one part of the question. And follow up to that is that how do the babies born with COVID do in terms of clinical survival, antibodies follow up, and also how does swapping benefit us? Swapping these babies, how does it benefit us? Since that we know that they don't transmit the disease or they don't get sick. So I think I can make it all one question. Is it swapping beneficial? Should they be positive? How do they behave? Do they transmit the disease or do they get the disease? Do they get severe disease? And if that's not the case, why do we have to swap them?
You know, when Billy called me to say, let's have this discussion, I actually cringed because nobody really knows where we're going with COVID well, especially in neonates. So number one, is it standard to swab all babies whose moms are positive? Yes. The recommendation, that is the South African guideline. We need to swab actually not just COVID positive proven moms. So even moms that are asymptomatic. So if you screen a mom and symptomatically you think that this is in keeping with COVID, we're ideally supposed to swab the babies. Are we doing it? That is another question for another day. Resource factors, patient autonomy as well. So it depends. So most babies that will get a swab are babies that are usually would be admitted to a high care unit or an ICU facility. And you will find that the babies that actually do get admitted are not necessarily ill from COVID. Most of the time, these will be preemie babies who will be having their own respiratory illnesses, cardiac diseases, abdominal, whatever challenge they might be having, or simply just by being small. So you do get term babies that will go to the NICU or the high care. So it is not necessarily that they're being admitted because of COVID. But then to answer the standard part of it, yes, it's standard. We need to swab COVID positive mom babies or babies born to moms who are COVID symptom related. And then do we need to swab these babies? That cannot be answered by me, because I'm actually, it's a very controversial question. I like it. I ask it myself all the time, that why am I swabbing these babies? 2 a.m. we need to swab these babies within 24 hours of being delivered. The latest that we can take it is 48 hours. It's 2 a.m. I've just been called, the baby's in respiratory distress. I can see this is a premature baby. Why am I swabbing this baby? What do I want to do if this baby is positive? And nothing. So are we doing it? Yes, we should do it for clinical research purposes, for follow-up purposes. Have we been doing it? I'm not quite sure. It's not something that I think I would comfortably answer to. And then what do we do when a baby has been is COVID positive? Do we need to wait until we get a COVID negative result? No. If the baby is clinically well, they will go home with or without a positive or a negative result. Do we have to wait until we know for sure that this baby was positive or negative when we first swabbed the baby before they can go home? No. But I can tell you, most of the time that we've admitted babies that are born to COVID positive moms, it's secondary to other comorbidities. And how many positives have we seen? I'm not quite sure what are the stats now in state. But then for me, I've only seen one, and she was not even sickly. It was a routine thing. I'm not sure if I covered all the questions. What was the other one, Joshua?
No, you've covered it. Thank you so much. So this calls for more research and more research, okay? Yes. So apart from looking at your mental issues, also look into research. Why do we need to have babies? Is there any clinical or non-clinical benefit? And quite very important, because we can't keep on poking these babies for no reasons.
Oh, sorry, Joshua, sorry to interrupt you. I think the last question was, what is a clinical presentation of a neonate with COVID? So the neonatal sepsis, it will still fall under that umbrella. They are going to present the same as with any other organism. The take-home message to even if it's a 6th-year medical student, they are non-specific. So it will still be temperature instabilities, blood pressure instabilities, change of color. So whether they are cyanotic or are they pale, whatever you're gonna see, respiratory issues. So they will present the same, whether or not this will be secondary to the COVID. So they can test positive for COVID, but you find that this patient actually has got a cardiac lesion. So it is non-specific. So because common things are common, the approach should be that even though I know that I'm swabbing a baby born of a COVID positive mom, I still must follow the standard protocol. So let's not neglect the rest of what we are supposed to be doing. So over and above everything that we've always been doing for many, many years before the pandemic came, we still need to go back to the basics and say, this is a neonatal sepsis case. If I need to ventilate, I'm ventilating. If I need to check on the fluids, this is what I'm doing. Start on antibiotics until you get a precise diagnosis of what you are looking at. So it will present similarly. It's non-specific. So still do the basics. Thank you.
Thank you. I think the latter that you have said is quite very important. We have seen what happened in the era of HIV pandemic, where people were not treated, neglected, as long as you test positive, and they forget that we don't treat the HIV, but rather the disease. So I'm afraid that we may follow suit, and kids get to be stigmatized, whereas, they're just COVID positive, but the issues that they're having, they are non-COVID. So quite important that we still manage patients, not as COVID. So I still challenge you to do a study in this regard, why we're swapping babies. Dr. Mawela, I see 4 hands. Do I still have time to take these hands before I ask Dr. Makakula one question related to vaccine?
Maybe start with the vaccine question, and then I will, in the meantime.
If hands are true hands or false hands. David Mudisel, Nkoli Iswa, Mapula Maunatala, Fulufelo Madzia, please check your hands are up. Can you just check if it's a true hand or not? If it's not, please lower your hand. Dr. Magagula. There's a question which says, are there any studies that shows that pregnant vaccinated women status has any benefits after their birth to the baby?
Yeah, well, I think the study that I just showed, that cohort study from the US with the 139 neonates, it's probably the one that shows that immunoglobulins are excreted into the breast milk. That's the one that I've actually come across, probably to answer this question. So yes, there is benefit to the fetus because the baby basically gets immunoglobulins from the mother. But as to how effective those are and how protective they are to the neonate, I think it's an answer that it's a question that's yet to be answered.
All right, thank you so much. So it looks like in the fetal, maternal, and parental and neonatal care, we need a lot of studies.
Indeed. Can I just make one other comment? You know, outside the question that you just asked me, I was very excited when I heard Amu speaking about the mental health issues to these mothers that actually deliver and they are COVID positive. Well, there's one study published in the South African Journal of Obs and Gynae. It's done by a friend, Reynold Mnisi. I think he published it in 2017 or so. Where they basically looked at the prevalence of postnatal depression in mothers whose babies are admitted to the pediatric unit, whether it's the high care or the neonatal ICU. And in that study, they found that the prevalence of postnatal depression was 43%. That's like very, very high. And we're not talking COVID right now. We're just talking normal admissions for whatever, a prem or a baby that's sick and all that. And the risk factors to this was, broken relationships, broken homes, lack of support, and all that. And I think probably Prof mentioned it when she spoke as well earlier, that the systems and issues in the public sector are actually quite problematic and not protective of these moms. So I think Amu raises a very, very valid point that many of these patients, they battle with mental health issues, even outside COVID, even outside anything. That is why in the antenatal period, us obstetricians have to ask that question: does she have any mental health issues? Does she suffer any kind of abuse? How is the situation at home? Because at the time of delivery, this actually has an impact as to how this mother will perform as a mother to this newborn baby, either admitted or discharged with the mother at home. So it's very, very important. And I think Amu must take up that research paper and probably give us more data beyond what Dr. Mnisi has said. And oh yeah, my other colleague, unpublished yet though, I think Dr. Jimo also was doing some work on mental health issues in such moms. So it's a big thing. It's very neglected, but it's one of those that actually give us poorer outcomes in the postnatal care of these mothers. Thank you.
Thank you so much. Amu, you are challenged again. Maria, can I give you one question before I take the hand of David Mudisale? It says, should the neonate born from COVID mom be separated from the mom at birth or stay with the mom, or only see them during the feeding, or they should be separated throughout?
Once again, I'm talking about a general case where it's a mom may be COVID positive, but she may be having mild disease or even asymptomatic, and baby as well. So we're not talking about a mother or infant who requires a different medical intervention. So under normal circumstances, the recommendation is that mom and baby can stay together and that they practice all the normal recommended skin-to-skin contact, bonding, etc. But that mommy pays particular attention to hygiene and mask wearing because of the risk of transmission through droplets as well as airborne particles and not the breast milk per se. So the benefit of the breastfeeding on one side, as well as the contact with the baby, or the other benefits of practicing, for example, skin to skin in terms of temperature regulation and the baby's overall safety, bonding with mom, etc. Those benefits remain, and we don't want to interfere with that. So unless there's a medical indication why mom or baby requires a specific intervention that would separate it, the recommendation is if there's suspected or confirmed COVID, encourage mom to initiate continued breastfeeding, counsel them about why, in other words, that the risk of transmission is outweighed by the benefit of that, enable them to remain together, rooming in day and night, practice skin to skin, including kangaroo mother care, especially immediately after birth, and then the establishment again of breastfeeding, because we know those benefits are greater than the potential risk if we take the required precaution in terms of infection control.
Well, thank you so much. I think they've been answered. Prof, before I go, one last question for you, sorry. Prof Pile?
Yes, I'm here.
Even Euro is asking, we need standard guidelines for all private and public sector for healthcare in terms of COVID, for perinatal care and early childhood. Do we have improved guidelines?
There are national guidelines, and it's currently being updated. So we have a framework for maternal and perinatal health, and there are flow diagrams as well. It should be available on the Department of Health website. There has been a working group that's been working on these guidelines, and they are being updated regularly. I think if we just look at the DOH website, there will be guidelines.
We'll get all of those and put them in our clinical care platform so that people can have access to those. David Mudisale, are you still want to, your hand is up, you have a question for us or a comment? David?
Okay. David, please unmute your mic if you want to make a comment. All right. Dr. Sukula, in the meantime, I saw a question and several people, it seems like there was a confusion around when to vaccinate pregnant moms. Someone even concluded that something about the third trimester. I thought there was a lot of confusion in the chat. So maybe I'm not sure between Prof and Dr. Magagula to really clarify when can pregnant women vaccinate. Someone was even saying something about teenage mothers who are planning to fall pregnant not vaccinating. I just think it's misinformation in a way. So maybe if you can state it simply, when should pregnant women vaccinate? I know it's a simple answer, but I think it needs to be clear and to the point. Thanks.
I'm happy to answer that. Billy, you can continue if you want to.
No, please go ahead, Prof. Thank you.
Okay. The initial recommendation when we did not have sufficient data, and you remember that pregnant women were excluded from phase 3 vaccine trials, the initial recommendation was that pregnant women only be vaccinated from 14 weeks onwards. But once, the US and the UK opened their vaccination to the public in December last year, and the recommendation from the maternal and fetal societies, RCOG, ACOG, was that women can be vaccinated in all trimesters. And as we collected more data, and there's been over 300,000 pregnant women vaccinated in the US, the guideline has changed. And in about July or August this year, the Department of Health has said that pregnant women at any gestation may be vaccinated, and the recommended vaccine is what is available to the South African public, and that is the J&J or the Pfizer. So either vaccine can be used at any gestation, but we recommend that women if they are planning pregnancy, that they be vaccinated prior to becoming pregnant.
Yes. No, thank you. Thank you for clarifying that, Prof. And then, Prof, whilst we are still there, just one more question. In terms of clinical care principles for a woman presenting with moderate or severe COVID disease, are there unique things that maybe clinicians need to be aware of? It's not a topic we have covered, but if there's the things that can differentiate, is it the same as non-pregnant people, or there are things that we need to be aware of? Thanks, Prof.
So we need to monitor these women as the non-pregnant individuals. They should have regular vitals checked. They should have their SATs monitored. We shouldn't be scared to do an X-ray on a pregnant woman because often clinically they appear well, but you see changes on X-ray, COVID pneumonia changes, which are not always apparent clinically. So we need to look at the clinical X-ray picture. It's also important to look at one's thromboembolic risk. And pregnancy alone increases one's risk of VTE 6 times, and COVID increases this risk. So we use a D-dimer as a screening test, and usually our guideline is that if the D-dimer is more than 1, then women should get therapeutic lactation, but all pregnant women admitted for COVID should at least receive prophylactic lactation. In terms of antibiotics, that would depend on the clinical picture and the X-ray. And if she requires oxygen, then she should receive dexamethasone or steroids. And then we also give the usual antibiotic vitamins that are given to non-pregnant individuals. So it's important that they're well hydrated. And then also because the virus binds to the ACE receptor, we see that COVID can cause a preeclampsia-like syndrome. So it can cause an increase in blood pressure. COVID can cause platelets to drop. It can cause your LDH to increase. So one needs to monitor vital signs, but also biochemistry quite closely.
Prof, you need to come back for that topic, but thank you very much for the highlights. I think the colleagues have grasped something out of that, but I think it's an important topic to look at. And then
Thanks.
Dr. Magagula, if the pregnant mom's age is below 18 years, what is the recommendation there? Do we provide by virtue of being pregnant, or we have to consider the age? I don't know what the experience is. Thanks.
Yeah, I'll probably ask Prof to contribute to this one as well. The eligibility, I know that we very soon probably will be starting at the age of 12. I've been hearing that it's, it's coming. Don't know if it's there yet. So this question will probably be answered by then. So yeah, I'll ask contribution probably from Prof, but as far as I know, all pregnant women can actually access the vaccine, and we're moving towards vaccinating children now. So I think she can actually be offered if she's less than 18. But of course, I'd welcome some other opinions and probably inputs from Prof as well. Thanks.
I agree. She should be offered the vaccine. Our government is using the age. We're using age to roll out the vaccine. So theoretically, any person under the age of 18 is not eligible yet. But we've got sufficient data on people or individuals between the age of 12 and 18 now. And I would encourage pregnant women under the age of 18 to get vaccinated.
Dr. Segolo, I hand over to you. I see we're out of time. I would have liked to ask more questions, but thank you very much, Prof. and Dr. Magagula, Maria, Amo. But yeah, Dr. Segolo, I don't know if you still have 1 or 2 questions. I see people are still typing and they're still here, but I think we try and sum up. Thanks.
2 hands, if you can just permit them while I'm taking 1 question on the chat, and then we should be closing the meeting in the next 2 minutes. Dr. Magagula, they say after how many days post-vaccination is it safe to fall pregnant? Unmute your mic, Billy.
I'm muted. As said, at any point, there's really no limitation as to when and how long. As said, you fall pregnant and then you can get vaccinated. There's no limit in terms of gestation. That's as far as I understand this. There's actually no limits and no real recommendation to say vaccinate and then 4 weeks later it's now safe. That's my understanding of it.
No, thank you so much. Olumbuni Adi Yejan, please unmute your mic and your comments or question quickly. We left with 2 minutes to close the meeting.
Hello, good day. Thank you very much, Dr. Magagula, for a wonderful presentation. My question is just very brief. For a mother who is HIV positive and also COVID positive, is breast milk still the best for the newborn?
Maria, you want to take that? Breast milk in COVID and HIV.
Thank you very much. And I'm going to ask Dr. Mawela to jump in if I'm not covering this sufficiently. But let's take them one by one and then we can put them together. So in terms of HIV, the target for us is to have mommy on long-term treatment so that she's viral suppressed and that reduces the risk of transmission of HIV. So that would basically be our priority. So if mommy is on lifelong treatment, perfect. And then we know the risk of transmission is very low and that's still safe. And then again with COVID, we do recommend breastfeeding. So in both instances, the benefits of breast milk for the baby, for the mom, in terms of immunity, the protection it provides against other diseases, against communicable diseases, and even over the long term against non-communicable diseases, because we know in the end it even protects against obesity later in life, etc., risk of diabetes, risk of breast cancer. So if we look at all the risks and we consider minor, if we look at all the benefits that are overwhelming and we look at minor risks, whether that is of transmission, we try to manage that risk as much as possible by ensuring that mom is viral suppressed and making it safer for the baby. So I think we sometimes focus so much on the risk while the benefits by far outweigh the risk. And then of course with that, counseling and support to the mother to do it as safe as possible, which would then include exclusive breastfeeding for the first 6 months. What is that? How do you do that? How do we support you? How do we ensure babies latching well so that you don't end up having bleeding, sore nipples, which increases the risk of transmission? But Lesego, if I have missed out on anything on the HIV side, you're welcome to just add to that.
No, I think we have covered everything. Breastfeeding is the recommended feeding option. Ours is to diagnose the pregnancy early, diagnose HIV, put mothers on ARVs, encourage and provide counseling for infant feeding, provide the infant with appropriate prophylaxis, and then continue breastfeeding for as long as the mother and the infant want to breastfeed. Thank you.
Dr. Mawela, the last end of Bandu's Misil and Duli, and then we close.
Yeah.
Unmute your mic.
Unmute your mic, Bandu. It's fine, Dr. Segule. I think we can.
I think we've come to the end of our session. Thank you so much, my panelists, Dr. Billy Magagula, Ms. Maria van der Merwe, Professor Pile Soma, and Dr. Amukelane Mtombeni. We really appreciate your time, that you've sacrificed your time from family to come and educate us in this clinical care platform. Our topics usually runs every Tuesday, 6 p.m. We discuss a variety of topics and different topics at all times. Being part of this clinical care platform, we appreciate you and you've added value. Your education was far more important than anything. And I hope all the attendees have learned so much and then going back to their communities, to where they work, their clinics, primary health level, tertiary health level, they will use the information that they've got here today. And we hope that you become part of this panel for future discussions. From my side, I thank you. Dr. Mawela, please, you may close the meeting.
Yes, thank you very much, Dr. Magagula, our panelist, and Segule for always chairing this session so nicely. Colleagues, this is a reminder to say a few things. Firstly, next week, we won't have a webinar. However, October is breast cancer month in the country, I think also internationally. So on the 12th of October, we are going to look at early breast cancer, focusing on the screening, diagnosis, treatment, and rehabilitation. We are going to have a panel of different specialists and rehabilitation teams looking at this problem at a different lens. It's going to be a case study where each of these specialists would then have their inputs on their approach and how to go about approaching patients who have early breast cancer. The webinar would be designed to offer expert opinion exchange and provide some practical approaches to early breast cancer management. On that note, just to say thank you again to you, our colleagues, for always joining us on Tuesdays. We are taking just a 1 week break, and then when we come back, we will continue where we left off. Thank you very much. Enjoy your evening. Thank you, Dr.
Thank
Segula.
you. Thank you. Bye.
Thank you. Bye.